So welcome back, everybody, to another webinar hosted from Princeton for everyone worldwide. We're very happy to have Esther Duflo with us today. Hi, Esther. Esther is from MIT and from JPAL for studying development economics. Today, she will talk about encouraging social distancing, evidence from several randomized controlled trials. And we're looking forward to hear Esther's presentation today. As usual, I will give some few opening remarks and put it in context, and then Esther will have the floor. So if you think about what are the main decisions individuals and institutions have to take, the COVID decisions because of the COVID crisis, individually, we have to decide how much social distancing we will do, whether we test or we don't test, whether to take a vaccine or not to take a vaccine. These are all important decisions with huge externalities on society. But there are also important institutional decisions, or governments have to make important decisions. And one is the communication to the public and how communication then feeds back into social distancing and testing and vaccination and so forth. Then there's lockdown, and there's also vaccine development and how you distribute vaccines. And there's of course a global good there. Global health is a global good. And it seems like, private institutions play a major role, like the Gates Foundation, JPAL as well. Probably more important role, almost like international institutions like the World Bank and others. So that's an interesting phenomenon we would like to understand further. And of course, there's some vaccine nationalism going on, and also some diplomacy that, you want to gain some other geopolitical advantages from providing some vaccines. So these are all important issues with regard to the COVID crisis. We will focus here, I guess, today more on the social distancing aspects. And of course, as I mentioned before, there's a huge externalities, and it depends what mask, for example, you're wearing. If you have these vents in the mask, that means you protect yourself, but you might still cause the same externalities on others. There are also interesting strategic substitutes, in a sense that if others wear more masks and if they're doing more social distancing, then actually you have to do less. So there's strategic substitutes rather than strategic complements. But on the other hand, one sees if others wear more masks, there's some social pressure to also wear a mask. So it's interesting how social pressure will actually translate into more mask wearing. It could also be a signaling that if others wear a lot of masks and are very careful, do a lot of social distancing, you might learn that they actually are very worried, and this might be a signal how severe the crisis is. So these are all rational explanations, all based more on externalities and strategic substitutes or complements. Here we have substitutes. But there are also behavioral aspects to it. And let me just outline two. And what I find very striking, how different the behavioral aspects are compared to the first wave and the second wave. Then the second wave in the fall. In the first wave, it was mostly fear. So people were very scared and were very careful. And one could see from many studies that, just the fear alone, there was no lockdown needed. The fear alone was enough to induce people to have a lot of social distancing. While in the second wave, there's what I call the COVID fatigue or even fatalism, that people really don't take COVID so seriously compared to the first wave. And it could be, one explanation would be optimal expectations framework, where you think about, how optimistic are you that you will not suffer from COVID, or at least you will have no serious complications from COVID. And if you have beliefs which are driven by anticipatory utility, so you want to be optimistic and look forward and overweight the positive outcomes and underweight the negative outcomes, that gives you more anticipatory utility. So on the one hand, you would like to be more optimistic because it makes you happier today if you believe that will not be hit by a COVID crisis. On the other hand, there's a force which makes you more rational, pushes you towards rational beliefs, that you're more realistic. That's because if you make the wrong decisions, if you don't wear a mask, you might be more likely to get a COVID, fall sick of COVID, and hence, you suffer from that. And you balance these two forces. And the question is, if the decision-making is very, very important to become more rational and get less anticipatory utility. But if the government takes on the decision and locks down, you can rely on the government, then your own decision is very much governed by the government, and you can essentially dream about the optimistic outcome. And that might be one reason why you can, be fatalistic or fatigue, you have suffered from the COVID fatigue. and get a less rational outcome. So the other thing is, and I think Esther will touch upon, is how to do the communication. What's your optimal communication strategy to convince individuals to do some social distancing? And there's different aspects to it. So one, you can actually arouse fear, as in the first COVID wave, where you can say, okay, everybody's scared, you scare them, and then they behave and internalize externalities. Or you can also create a sense of community. So we're part of a community with a common threat, and we try to fight this threat together and internalize externalities. You can also create some backyard competition across different regions in a country. We're saying, okay, we are below, we vaccinate faster than the other country and or region or even county. And that also is a way to incentivize people to behave more responsibly. Generally, the communication is very challenging because you have to convey information, what would happen if you don't behave in a particular way. So you have to essentially convey the information about counterfactuals, and that's very hard to convey in a credible fashion. And there's always, you know, some conspiracy theories are coming up. And here, what I've shown here is a death rate in Germany, and you know, you see a band of potential death across the min and the max from 5 years before the COVID. And then you see the death rate during the COVID crisis. That's this brown line. And what you see, actually, the death rate was actually not so different, you know, if you take the max and the min from the previous years. And it only really made a huge difference then in December in the second wave, where the death rate really significantly outperformed the error band you have earlier. And this way, you know, if you behave, if you do some lockdown and hence the death rate is low, people would say and have conspiracy theories, it's not so bad, it's just a bad year with a serious flu. And then you cannot convey convincingly that that's actually, it's only the case because of the lockdown measures. And because of the lockdown measures, the death rate is so low. And the counterfactual would be way more severe, much more dramatic. That's very hard and very, you know, difficult to convey to the public. And that's the challenge any policymaker is facing, to convey the counterfactual. And what you do, essentially, what you're forced to do is to let the counterfactual get a glimpse through to the counterfactual. You open it up a little bit in order to see how it goes, and then it becomes more convincing, and then people become, you know, more convinced that there's a real threat, and then behave more accordingly to the rules. So with this opening remarks, let me just go to Esther's polls question. So she asked 3 questions, and the answer is always you know, as of September 2020, who is more likely to always be wearing a mask outdoors? Are these A, the African Americans, B, whites, Democrats, C, white Republicans, or are they all the same? And the answer in the survey you gave us were 16%, 70%, 0%, and 12%. Okay, so that's, you know, the biggest impact is on the white Democrats, and there's almost no impact on the white Republicans, although essentially they're not wearing the mask in September 2020. Now, whose knowledge on the COVID-19 is most affected by a short video message by a racially diversified group of physicians from the Massachusetts General Hospital? Same answers again. I mean, African Americans, white Democrats, white Republicans, and all the same. The answers were 45%, 39%, 5%, and 16%. And the third question was, whose willingness to pay for a mask is most affected by a short video message from a rational diversified group of the physicians? And the answers were here, 42% the African Americans, so big impact on the African Americans, 26% on white Democrats, 9% on white Republicans, and for all the same, 22%. So these are your answers, and we are curious to listen to Esther's perspective, or what information she could figure out, and what insights she will give us on using randomized controlled trials, one area where she is very, very famous for and has implemented it across the globe, also through JPAL, a very important institution she set up in the last 20 years. Thanks again, Esther, and it's great to have you with us. And the floor is yours.
Thank you very much. Thank you, Markus, for inviting me and for being patient. The advantage of waiting to give this seminar for a long time is that I have many more things to share with you today. I'm going to share my screen if I can. So this is a joint project with very many people. You have a list here. It's actually a big collaborative project between economists and doctors, many of whom are at MGH or Harvard Medical School. So as Markus pointed out, before a vaccine was available, a behavior change like social distancing, mask wearing, hand washing were the only tools available to protect oneself and others against COVID-19. And even now that we have the vaccine, communication remains critical because a lot of people do not trust this vaccine and they need to trust it in order to take it up. So this is not something that is particularly original. Immediately, as soon as the pandemic started, the information started and people were bombarded with information and disinformation through radio, through TV, through social media, and it's sort of continued. And one of the movement in people who tried to make a difference, to try to be heard in the middle of this cacophony, were a series of credible people by which I mean people ranging from football stars to Dr. Fauci, to the local doctors, to try to kind of go on the internet and convey the most relevant information and advice at any point in time. And so in a sense, I was also there with my group of co-authors in March 2020, trying to see what can we do to make a difference. And communicating on the value of protection is something that I have done a lot of work on in India. And along with many of my co-authors, that was also their work that they had done. So we kind of wanted to get into this as well, but we also wanted to know whether it makes a difference. So there are only two questions that we were after. One is whether this kind of light touch campaigning of these messages do make any difference, or whether it gets drowned either in the noise or in the politics. And in particular, mask became a political issue, then travel around Thanksgiving and Christmas became a political issue. Does all of this noise drown the useful message? And finally, does the information need to be tailored to particular groups to be effective? Do you need to have special information for African American? Do you need to have special information for Republicans or Democrats? Or can the same information touch various kind of people? So this is a whole group of projects I'm presenting today that we are been engaged with since the March 2020, essentially, to determine precisely that and to do it at scale in the sense that hopefully we would also make a difference along the way. So the first study has a very long title, but we call it the Banerjee effect for reasons that are going to be clear in a minute. And this is the first study we launched, and it was fielded in West Bengal in India in May 2020. So India, like the US, had a big lockdown. And in early May, there was already loosening of some restriction. We intervened precisely at that time. At the same time that the lockdown happened, the population was literally bombarded with messages about COVID-19. Our respondents heard 20 messages on social distancing from a source or another over the last 2 days. So people had reasonably high knowledge level, but compliance was not universal. Again, people tell us that only 2/3 of people claim that they wash their hand. 37% had traveled outside the village in the last 2 days, even if it was forbidden. And on average, in the last 2 days, they had 11 interactions that violate social distancing. So the question is, in the middle of this heavy communication, could a nudge from a reliable source improve compliance to these behaviors? And the question we were faced with is who could be our reliable source? So initially we decided we were looking for a star, like a cricket star or a Bollywood star. And eventually we were persuaded by one of the person on the team that actually, who was not Abhijit Banerjee, that we had our star, which was Abhijit Banerjee, who happened to have won the Nobel Prize in Economics in 2019. He's also the chair, was named as the chair of the COVID-19 Scientific Council. So he doesn't have Fauci visibility at all, but he's still, for West Bengal, the person who kind of embodies a lot of the advice that can be given to the government on the science. And he's a well-known figure in West Bengal. So we decided to try with him. So what he did is that he recorded very short messages on his cell phone, actually on my cell phone. And we decided that we would go with only him as the messenger, with the idea that it's the most credible person we have at our disposal. So we'll try to see if it makes a difference. But we weren't sure about the optimal content of the message. So we had various content of the message. So some messages, and this is related to what Markus was talking about the motivation for action. So some messages emphasized behavior. So are you doing that? Do we insist on one behavior versus the other? Some messages insisted on the motivation. Do you do that for yourself because you might die or you might get very sick, or to protect others? Do you talk about the social norms or not? So the messages were randomized at the equivalent of the zip code level. And in total, they were sent to 25 million people who were all the subscriber of one particular network in those villages. And we left out of this first wave of messaging 3 million people who were in untreated zip codes in order to measure whether the messages are effective at all. So in those places that just got an SMS linking them to the government website. And we also varied the type of messages that they were getting. And what we're finding is that and then in order to look at the impact of this, at this point,
Esther,
we didn't have.
Tell us how many people live in West Bengal, just to get what's the coverage?
Oh, what's the coverage? Maybe 100 and some million, 120 million.
Okay.
So we were not able to survey all these people at the time. There was not yet the kind of Facebook or others mobility data that would be able to use later. So we fielded 2 surveys, one with the health workers who were able to tell us whether people report symptoms, because that's the one thing that we told everyone, that was told to everyone in the message, is if you have any symptom, report them. So we conducted a survey very soon after the treatment to see whether people do report symptoms. The treatment didn't cause symptoms because it was within 5 days of the treatment, but we wanted to know whether the reporting would increase, which was critical to the government response. And then we also collected a survey of Panchayat members, which is a large database that allowed us to ask questions about themselves. So the Panchayat member are the member of the local government, past and present. And we also asked them to report about others in the village. So what do we find in this experiment? So we find that the intervention, to our own surprise perhaps, was actually effective. In particular, the reporting of symptoms to the ASHA doubled in places that were treated. So clearly there was a piece of information that people either didn't have or didn't trust, and then they implemented when they got the information. And also, if you look at the various behavior, you see an improvement in getting outside of the village. And also, although that looks very close to 100, a lot of people report wearing a mask, that actually went even closer to 100 in the treatment villages. So overall, the intervention was effective. There is a few more results that are interesting. One is that none of the variation made a difference. So the content of the message didn't really matter. What mattered was to get the message. The other thing is that there were very large spillovers onto the behavior of the non-geo subscribers. So in each village, we could initially only capture the people who belong to the geo network, because that's the one who gave us access. But the survey was also of non-geo subscriber, and the effect on them is essentially as large as the effect on the geo subscribers. So that suggests that the information actually does circulate once it is given. So it didn't seem to affect what people knew in this case, but it seemed to affect their willingness to act on what they knew. So that suggests that actually, despite the ambient noise, there is a significant benefit of a continuing messaging campaign, at least by this credible source. Of course, we didn't have a non-credible source to compare to, but we at least have this positive message that continuing to message by a credible source matter. So just in terms of the implication of that work, given that it worked, it's essentially free to do. Abhijit, in his role as the head of the commission, got a chance to have those messages later. We couldn't evaluate them. They were sent to now everyone, so literally tens of millions of people. He sent a series of messages asking people to treat well the people who have COVID, because for a while they were abandoned. He sent a series of messages very similar to what we are going to see at the end of this talk, asking people to be careful around the big Durga Puja holiday, to stay home, and if they travel, to be careful. We don't know the effect of that, but we know that a lot of people got these messages, so it had an immediate sort of policy action to launch this project. So that's the first project that's the first study for West Bengal.
Can I ask you something which is specific to India? There's a lot of talk that the migrant workers played a huge role, bringing from the cities the COVID crisis to the countryside. Was there any way you could explore that as well, or did you explore this as well? Or is this
no, so we didn't. We couldn't do that. So you're absolutely right that the lockdown was announced with almost no warning. Mm. And at the same time, people got lost access to their job and their place of being in the places where they used to work. So this prompted a huge movement of people towards the countryside. And therefore, two impact, an immediate impact, which is a lot of these migrants had massive problems going home, some dying along the way. And also an indirect problem that it did bring the COVID to the countryside and ensured basically a rapid spread towards the beginning of the crisis. But this project was really focusing on on anybody who was, at least whose phone was registered there.
Mm. There's a question: could or did the GEO subscribers forward the message to non-GEO subscribers?
They could, and they did, although we were unable to measure it systematically because we couldn't get the whole metadata of what they did with the information. We just knew if they opened it, but it's something that they could do and that they did. But I believe that part of the spillovers is also via talking to their friends, because we did see actually an increase in people talking to each other about COVID.
Mm-hmm. Another question which came in is, the government must have also communicated in a particular way. How did it compete with Abhijit's communication, or was there some?
Oh, it was like a slugfest of communication. Everybody was communicating left, right, and center. The government, the stars, everyone, some serious, some less serious. So the amount of communication was incredible. So in that sense, and then all this communication was probably to some extent competing, which is why when we launched this project, we weren't particularly confident that it would make a huge difference. And that's why for example, we decided to only do this project with Abhijit, because it was our best foot forward in term of trust. It is actually quite surprising that even in this context of information overload, just this one more message makes a difference. If you remember, they got 20 messages. Our people that we surveyed got 20 messages in the last 2 days about COVID-19. So clearly, it's not the only one that they got. So unless there are other questions, I will now completely move continent and move to the US, which is first two studies. If this was a very, very large scale, very simple, very action-oriented project in West Bengal, we moved to 2 studies that were more to try to understand some mechanism about who is trusted and why, which we did in the US with US doctors. As you here have the title of the 2 studies. And let me give you a bit of context. So in the US, the COVID crisis has been described as a syndemic, which is the combination between the pandemic and the epidemic of systemic racism, which predates this particular pandemic, obviously, but was revealed in many ways, particularly starkly by the current situation. So there were, for example, 1.4 times greater cases COVID-19 rate in the Black US population, and adjusted for age, 4 times the death rate is 4 times higher in the Black US population. In this context, many physicians have tried to reach out to people, not just Black, everyone, directly to encourage social distancing, not traveling around Thanksgiving, Christmas, etc. And it makes sense. So doctors have been taking to Facebook. This has been relayed in the press as well. And it makes sense because in all the polls, doctors and nurses are among the experts that are most trusted in public opinion, much more than economists. For example, in the survey we did in 2018, 84% of people trust doctors and 25% of people trust economics. So that makes sense, but that still raises the question again, is such physician communication effective, particularly in the polarized context that in the US, where a lot of this became political statement? Second, does it effectively reach Black Americans who bear the biggest burden? And third, can anything be done to make such communication more effective for Black Americans? So what we did is we contacted a bunch of doctors who were mostly working at MGH or also in other Boston hospitals, smaller community centers in Boston hospital. And we worked with them to develop a few messages to inform the public about COVID-19 that would be relevant, not just to the to white, but also to African American and Hispanics. Then we recruited people online all over the US using the Lucid platform. So that's an online surveying platform. And we focused on low-income Americans with less than college education. So in the first study, we had about 11,000 Black and Latinos, and it was done in May, so about the same time as the West Bengal study. The second study had 20,000 Black and white in September. And that's very relevant because this is the time of the COVID fatigue that Markus was talking about. And so the result could have been quite different. Let me try to show you an example of a statement and how it was read. So here is a doctor. So she's wearing her medical garbs. And this is very early on in the epidemic, so she's going to say a few words about COVID-19.
Hello, I'm Dr. Kwete from the Massachusetts General Hospital, and I'd like to tell you a little bit about coronavirus or COVID-19. COVID-19 is a new virus that can infect the respiratory tract and lungs. Although many people who get sick from COVID will get better, some people who get it become very ill and some even die. Although there's no cure, there are ways medical professionals have found to protect you and your community from COVID. I hope that this message can give you information that will help you protect you or someone you love from COVID infection. First, I'd like to tell you about the symptoms of COVID-19. The most common symptoms of COVID-19 are cough, fever, and trouble breathing. Another odd symptom some people have is loss of taste or smell. A large number of people who have COVID-19 actually don't show any symptoms at all. Unfortunately, people can still spread the disease to others even with no symptoms. The next video will provide you with more information on how you can protect yourself and others.
Hello, I'm Dr. Brown from the Massachusetts General Hospital, and I'm here to share tips on how to protect you and others from transmitting COVID-19. The absolute most important thing for people to remember is to be at least 6 feet from every other human being. Well, what does that mean? Whether you're outside, whether you're shopping, whether you have to go to the pharmacy or grocery store to get essential supplies, be sure to stay at least 6 feet from the next person. Know exactly where your hands are at all times. Be mindful of what you touch, and be sure to wash your hands or use hand sanitizer on a regular basis. When you get home, be sure to disinfect everything in your home that comes in contact with your person.
Hello, I am Dr. Asishana Osho from Massachusetts General Hospital, and I was hoping to tell you a bit more about masks. Wearing a mask is a key way to prevent the spread of COVID-19. You are not just protecting yourself, but also your grandmother and your community, just in case you have COVID-19 but don't know it. Even if wearing a mask may sometimes put you in a difficult situation, it is important to protect you and the community from COVID-19 disease. As a medical professional, I am committed to delivering the best care I can to every patient. My goal is to make sure that you and everyone you love survives this COVID-19 pandemic. Thank you for listening to these messages.
So you have 3 videos, you've seen her face, you have 3 videos, and they each read 3 information statements about COVID-19. So in the first one, she describes the disease and its symptoms. In the second one, she literally reads out, or she or he, because it could be a different one, literally reads out the CDC advice at the time on social distancing. And the third one is about masks. This was early in the pandemic where there was no recommendation yet from the CDC, but it started to come up. And there was a bit of a question on how African American in particular would be perceived if they were wearing a mask. So that's the third one. Then we varied various aspects of the message I'll describe to you and the messengers. And then we surveyed immediately online to measure basic immediate outcomes. So here we want to see whether the video in general have any impact on knowledge or on intended behavior. We were also very interested in who is trusted, and in particular, Marcella Alzen, who is one of the co-authors on the project, has a lot of work on race concordance, which is that you're more likely to trust a doctor who is from your own race. We wanted to see whether acknowledging injustices in healthcare and in economic lives would affect the credibility of the message. A lot had been said about Dr. Birx, the White House doctor, as being a very polarizing figure and not really trusted. So we want to see whether she would be just as effective as an MGH doctor. And then the last treatment was about the social perception of mask. And I'll describe that to you in a minute. So first we recruited. Then people were randomized to either receive the intervention or not at the individual level. And then, as in the West Bengal study, there was variation in either the concordant or discordant doctor, the type of statement they were getting on inequality or not, and then whether they received the social norm treatment on mask or not. If people were involved in the control group, they received the information as well, but after they had completed the survey. So the first randomization is the concordant or discordant. So we had doctors that were Latinx. So this is Dr. Carlos Torres, who were Black. So this is Dr. Kemar Brown, and who were white. This is Dr. Kelly Holland. Here I put all men, but we also had the same number of women. So the gender was also randomized. So people were so Latinx were either assigned to a Latinx or a non-Latinx white, and Black were either assigned to a Black or a white. And in this particular study, we didn't have whites. Then there is this question that Markus asked about social norms and how are you perceived if you are wearing a mask? And early on, there was some ambiguity. So a lot of Latinx didn't want to wear masks because they were worried that they would be perceived to be sick and therefore people would not come to their businesses. A lot of Black people didn't want to wear masks because they were perceived to be up to no good. So the first thing we did before doing this project is we showed people, our sense was that the social norms were actually evolving very fast. and therefore that people were potentially wrong on the social norms. So we showed people some photos and we asked them to tell us what they thought about the people wearing the masks. And it turns out that 8 out of 10 people at that time in April thought that someone wearing a mask, a Black person or wearing a mask, is actually protecting their community, not sick or up to no good. So the social treatment was to share that information. So what did we find? So this bar chart just compares the intervention to the control. So any form of intervention to the control. And this shows the knowledge gap score. So you can see that a gap of 0 means that you answer correctly to all the questions we asked on COVID, symptoms, and prevention. And a gap of, the larger the gap, the less you know. And you can see that the intervention was very effective at affecting knowledge because many fewer people have a gap of 0 and instead have a gap of 1 or, sorry, many more people have a gap of 0 and fewer have a positive gap. So there was, despite a high level of original knowledge, there actually was an effect of this intervention on knowledge. However, for this particular intervention, the only measure of behavior we had is we asked people to click on links to get more information. So we were interested in whether they would click on links from how to make a mask, how to exercise at home, the site to get tested and all that. And we didn't find an effect on average on the demand for links. So unlike the West Bengal study, we didn't find an effect there. The only place where we find an effect, the only people for whom we found an effect are the African-American when the doctor was African-American. So this showed you the demand for link by African-American. And you can see that we are more likely to have 4 more links asked if the doctor is African-American than if he is not. But even that effect, it was not extremely large. Still, we thought it was encouraging that still we thought it was encouraging that the demand for that there was an increase in knowledge.
So there's a question from the audience from Matthew Nidal. He thinks that, you know, African Americans typically trust their doctors less, and so your finding is then even more surprising in a sense. Would you agree with that, or?
I think African American trust white doctors less, maybe. Or I don't know whether this applies. It is clear that there is prior evidence showing that African American trust maybe doctor less in general, and certainly, but then Black doctors more, in particular when it comes to preventive care. But yes, it is striking that the effect, there was a fairly large effect on knowledge, and there was an effect, small but present, when the doctor was Black. Another thing that was striking is that, again, like in West Bengal, there was no impact of any of the other differences. So in particular, Dr. Burke's, people hated the video. We asked them to rank the video, and they really didn't like the video, but it didn't affect their knowledge retention or their demand for link. The social norm messages, when we inform people that 8 in 10 Americans think that wearing a mask is protecting a community, they heard the message, because then they gave us their posterior and they said, yes, that's what most people think. So it did affect the perception on the social norm, but it didn't affect behavior, even for people whose opinion was shifted the most. And the acknowledgement of inequality didn't make any difference. So far, so good. The doctor video does appear to be effective as changing knowledge, but there was limitations in this study. The first one is there was no hard measure of behavior, even self-reported. All we had are those links. We didn't have the whites. The environment really changed over the summer. There was, first of all, during the spring, the racial justice protests, and then in the early fall, the polarization as we get closer to the election, and then there was this COVID fatigue of people getting tired and they were respecting the prescription less and less. So before we could think about recommending scaling up, we thought we had to do a second study that was addressing this various open question. So the second study, we still want to do a little bit the same thing, whether the video have any impact, but this time with measures of behavior a little bit more reliable. Continue to look at this idea of concordance. And then it was also a time where everybody thought it was important to put out a statement against systemic racism. The American Medical Association was no exception. So we wanted to see whether those kind of statements affect the attention of people who receive, and also whether they have possible backlash effect with any type of population. So we launched another project, very much the same kind of idea. People with our same group of diverse doctors. And what we did before launching the project is, before launching the video, they got to see an actor. So I'm going to show it to you. So this is our actor who is delivering the statement.
The American Medical Association recognizes that racism in its systemic, structural, institutional, and interpersonal forms is an urgent threat to public health, the advancement of health equity, and a barrier to excellence in the delivery of medical care. The American Medical Association opposes all forms of racism. The American Medical Association denounces police brutality and all forms of racial-motivated violence. The American Medical Association will actively work to dismantle racist and discriminatory policies and practices across all of healthcare.
And what he's saying is a statement that the American Medical Association gave in June, which recognizes systemic racism as a health threat, and is against it. And then, so half of the participants, before seeing our own doctor, saw this statement, and the other half saw a sort of placebo treatment, saying that the American Association supports transparency in drug pricing. So this is, after they saw this, they had, we separated the group into a treatment group and a placebo group. In the first, this time we thought of having a placebo, so everybody has a study that is the same length. Very much the same type of information, introduction of symptom, social distancing and hygiene, and then specific information about mask. The study has had this time 10,000 white people and 10,000 Black people. First, they were randomly assigned to the AMA anti-racism statement or the placebo. Then they were assigned to a Black doctor or to a white doctor. Then they either received the COVID messages or they didn't. And when they received the COVID messages, one of the things that changed is we either insisted that about this big difference between Black and white mortality or not. The process was very much the same, with one exception. We were able to follow up with a group of people a few days later, so we could actually have self-reported measure of actual behavior. The attrition was, however, very high, so this is not, that's not the only thing that I'm going to rely on. So we are going to measure how much they learned. We are going to measure how much more they want to know. Importantly, this time we were able, because masks were available to sell, we got a measure of willingness to pay for masks, which were incentivized. And then in the survey, we got a safety gap measure on wearing the mask indoors, outdoors, washing your hand. And the last outcome was we told people we would allocate $1,000 to a donation, to a charity. And how much do they want to allocate to COVID versus Alzheimer was the first choice. And the second choice for another donation of $1,000 was how much they want to allocate to the BET COVID Relief Fund, which was focused to African Americans, versus the Give Directly program, which was focused to all low-income families. So this gives you a sense of the priority of COVID versus other issues and the priority of Blacks versus the population at large. So let me start by the first, by some descriptive statistics that have to do with the poll, the first question in the poll. So the first question in the poll was, who is more likely to be wearing a mask? And most of you said, and I asked you to compare between Blacks, white Democrat and white Republican. By the way, the reason why I didn't separate the Black between Democrat and Republican is in our survey, most of the Blacks are Democrats. So that wouldn't make sense to separate. So you were not completely correct because in fact, it turns out that in September, Black were much, much more careful than whites. So on average, they were twice as likely to be wearing a mask outside than whites. And again, between the whites, Democrats are more likely to be wearing, twice as likely to wear a mask than the Republican. But still, it's by far the people who are most likely to be wearing a mask indoor, outdoor, washing their hands, etc., are the Blacks. So if they are more affected by the COVID-19, it's not because they haven't understood that they needed to protect themselves, because in fact they adhere very closely to those predictions.
Did you conduct any other surveys what people think the other groups are doing? So it's quite striking that people think that the African Americans are not so careful, but they're actually more careful.
Yeah, so it's a great question. No, in this one we didn't do this second order beliefs. We did second order belief we did beliefs on what people think the differential on mortality, but we didn't do beliefs on what you think other people do. That's a great idea. As this poll shows, and in fact my own prior was not that order. My own prior would have been white Democrat, Blacks, and then white Republican. That was incorrect. So that's a first surprise without even doing, before we do the intervention, that's at baseline. Now, what's the impact of the intervention? So here again, we see a large impact, in fact, much larger impact on knowledge than in the first intervention, starting from levels of knowledge that are worse. Now, of course, it's not entirely comparable because the questions were harder, but almost nobody has zero gaps in knowledge in the control group, very few people. You see an increase in the number of people who have zero gap in the treatment and an increase in the number of people who have just one gap, and it comes from the rest of the distribution. So this is everyone together, Black and whites together. So quite striking effect on knowledge as of September, despite whatever they might have learned and despite the COVID fatigue. The second thing is that here, unlike what we had in the first study, we do find a significant increase, not large, but significant and real increase in the demand for more information. Which is for us a measure of intended behavior. So there is fewer people who want zero link, and that on average that difference across the distribution is quite significant. So there is an effect in wanting more information. There is also an increase in how much people are willing to pay for a mask. So the willingness, this was willing to pay for this, not just one mask, that would be a very expensive mask, but it's a packet of very high quality cloth mask. And you can see an increase in about 50 cents over an average of $14 in the intervention group. So people who get any form of intervention, and again, this is everyone so far, are more likely are willing to pay more for a mask. And finally, at endline, in this group that we were able to follow, we see an increase in the number of people who practice all of the safety behavior, and a decrease in the number of people who practice none. So there was, again, this is not a very large effect, but it's significant overall for the population, where we see an improvement in addition to the behavior as we can measure it. There was also an increase in how much people were willing to give, wanted us to give with our donation to the COVID charity. It went from $519 to $538, and to the Black charity as opposed to the general charity in the intervention group. Again, that's across all groups. Now, is there any effect of the variants of the treatment? So to do that, we interact each of the variants with a treatment dummy, and again, we find very little. No impact of behavior of anything. The AMA anti-racism treatment, the Black doctor this time actually did not affect, white doctor was just as effective as changing behavior of white and or Black than Black doctor. These were the same group, by the way, so it's not a change in the actors. But in this, there was no concordance effect left. There was an effect for everyone this time. And acknowledging the disparate burden didn't change the effect as well. The only effect that we found is that when we acknowledge the disparate burden, this made people, both white and black people, more likely to want us to allocate more money to black as opposed to everyone. And the effect was larger for black, but the same for everyone. The next questions are going to, I'm almost done, so I'm going to quickly give you the next question on who is more affected, because you gave us that in the poll. And you said that, I think you said that the effect on knowledge gaps would be larger for blacks, but in fact, they are the effect on knowledge gap are the largest for Republicans, for white Republicans. So the effect on knowledge are the largest for black Republicans and the smallest for black. However, the effect on, so this is the opposite of what you were saying. However, the effect on behavior, either intended by willingness to pay or actually observed in safety gap, are all the same. So white Republican, white Democrat, and black, who are almost all Democrats, are all affected similarly by this intervention in terms of their willingness to act. And if anything, if there is one group that is most affected, it's the Republican.
But is it because they have a flatter prior in a sense, they didn't know so much yet, and then they learn?
No, they know a lot. You can see the white Republican, they are actually, the white Republican are the one with the lowest knowledge gap to start with.
I see.
The white Republican they know a bunch. They start with a slightly higher knowledge gap. They end up with the white Republican and white Democrat have a similar knowledge gap, but they have a larger effect. But they are not very similar. Dissimilar. In terms of action, you can see it here that yes, their willingness to pay is lower, for example, but it increased by the same amount as it increased for the Democrats or it increased for the whites.
Do you also control for other things? Are the Republicans wealthier or live in different neighborhoods? Is there any way to control?
So we looked at different things. How things get cross-cut by different things. And basically we find very homogeneous effects across education, across income. We find that everybody is sort of affected in the same way. And again, I think this doesn't correspond to the prior that this group had. This didn't correspond to my prior either, especially given the level of polarization around mask. I would have assumed that a black doctor telling a white Republican that they should be wearing a mask would not be effective. And in fact, that's not true. It's just, there is just no, even though they start from a lower level in terms of their adhesion to this behavior, the effect is the same of the intervention. So this really made us happy because now we can see, wow, this is actually, it is effective, not only in terms of changing behavior, but in terms of changing knowledge. And we can go with fairly blunt instruments because that has a chance to be effective for everyone. So at this point, we got contacted by Facebook, who has a group called Data for Good, who was interested in doing something. And what they did is that they gave us a lot of ad credit, free ad credit, to transfer, to give to people very simple messages in the form of ads. So the first experiment we did was just before Thanksgiving. And the second experiment we did was just before Christmas. And in both cases, the advertisement was a 30-second statement by a doctor encouraging people to stay home for the holiday.
I'm Dr. Warner from Harvard Medical School, and I'm urging you, don't risk spreading COVID. Stay safe, stay home.
So that's what they saw, and we had a very similar one for Christmas. It was pushed as sponsored content to a lot of people. In Thanksgiving, 11 million people saw a study message at least once, and in total we sent 30,000, so a lot of people saw it about 3 times. In Christmas, 23 million people saw it, and 80,000 people video posts got sent. What we were intending to do is full saturation of all the Facebook accounts in treated county, and we treated half of 820 countries in 13 US states. And I'll show you the results. The first result is on whether people travel before the holiday. And to our own surprise, you're finding both at Thanksgiving and at Christmas a significant effect on the kilometers that people traveled just before the holidays. It's not such a high number. They travel on average 4.5 kilometers less in Thanksgiving relative to February. But in our treatment group, just before the holiday, people were traveling significantly less. What we do not find is a decline in staying home. We find no effect in actually being physically in your home on the day of the holiday. People might have been visiting people who were living close by, or they might have gone for a hike. But what is clear is that they were less likely to go somewhere the day before, to take the car or take the plane to go.
So this county fixed effects or some state fixed effects in this?
So this is randomized at the county level. So and then yes, there is strata for there are effect for strata by pair. So this is the county. Imagine that the county that are treated are exactly the same as the county that are not.
Yes. I was just wondering because the first wave was in the US very different in terms of timing.
Yes. So we were looking at we chose the county in places that were that had a lot of COVID-19. And that also had COVID-19 data available for us to look at further. So even this 30-second video message that was superficially maybe not well received, we got a lot of negative comments corresponding to the politicization around this idea of traveling for Thanksgiving and whether it's a duty to go visit your family at Thanksgiving. But yet there was this effect, this effect on people actually traveling less, which is not negligible compared to the mean of how much people were traveling during this time. We don't have impact on staying home, so we don't know what the net impacts are. If in order to do that, we have to look at COVID-related outcomes. Even though the sample was enormous, it's not clear we'll find effect there, but we are working on it. But it is already quite striking that exactly like in the Abhijit study, with the doctors, these very short messages changed people behavior at scale. So in conclusion, despite the ambient noise in information, light social media-based information campaign get people to change their behavior. And what is striking is that even on topics that appear to be ultra politicized, like traveling on Thanksgiving or Christmas, wearing a mask, people seem to be affected by simple messages, regardless of their race, regardless of the politics, regardless of the race of the messenger. So beyond COVID, I think the good news, especially in the current environment in which we live, is that people still seem to be responsive to actionable information and willing to listen to it a little bit, regardless of their conviction on other things.
Great, thanks a lot, Esther. Fantastic. This is really a wealth of information. Actually, will help many policymakers and how to design communication strategies in the future in order to get the messages across and impact behavior of the public. So let me ask some questions which came in the audience. One question which came very much, and I think you answered already by Thomas Nakovic. He would like to know whether a big difference between urban and countryside. Did you find anything along this dimension, or wealthy and not so wealthy neighborhoods? But is you
yeah, so we looked a little bit at heterogeneity. We need to do that carefully to make sure that we are not finding something because we look too closely at it. But so far, the biggest difference we found is more that the effect was lower in pro-Trump urban places than in other places, either rural or Trump or not, or urban. So there was not a, so that's why we were wondering whether we kind of quickly did that between Thanksgiving and Christmas. This applies to Thanksgiving. We quickly did that before Thanksgiving and Christmas to make sure that we didn't include a place in the Christmas campaign where the effect would have been negative. Because we don't want to do any harm. So, and we didn't find places where the effects are actually are counterproductive.
Another question by Mark Greenblatt. He would like to know, you focused very much on social distancing, but there might also be now new messages about vaccine, participating in a vaccine distribution. What is your lesson from this study, how communication should be to convince people to participate in vaccines? And, you know, would you vary it from country to countryside or urban structures and so forth?
So what we learned from this study, in a sense, is that doctors who are already out informed to try and convince their people to get the vaccine should continue. That's going to continue to be effective. In a sense, this, again, to the extent that there are other studies, for example, there is work by Marcella on the flu vaccine suggesting the importance of racial concordance for African Americans to get the vaccine. So for the vaccine, I would like to, I imagine that we will get into once there are more vaccines around and it becomes really a choice for people to get the vaccine. I would imagine that we would be involved or try to be involved in vaccine projects. And I think the question of concordance is not solved, which is it is possible. In this study, in one case, we found that it was important to change behavior to have African-American doctors speak to African-American, and in the other, we didn't. But because vaccine is much more invasive and there is a much bigger question of trust than in wearing a mask, I think one would need to try out whether concordance is important in that context. And then if it's important for race, then you might imagine that it's also important for other dimensions. For example, rural areas, you know, you might want to have like the local doctors. Even for our second wave for the Christmas campaign, for example, we didn't just have doctors from MGH. We had doctors from Bozeman Health in Montana and from Colorado, and we had nurses. So we try to be more diverse, not just racially, but across the various dimensions of heterogeneity in the US.
But would you go so far that, you know, when we distribute the vaccines, we can do it locally, doctor by doctor, or we can have some big centers where the vaccine is much more, you know, hundreds of people come every day to the same spot to get the vaccine?
So that's a question that to which this study has nothing to say. But there are other work showing that even small barriers to act for something like a vaccine, which is a preventive gesture, can have a disproportionate effect. And in that sense, anything that I would argue, but not based on this study, but based on other things we know, that you know, having just huge vaccination centers is like anti-nudge. It makes it all the more difficult. And therefore, if it can come, once we have vaccines that are easier to handle than the Moderna and Pfizer vaccine, getting it as close to the people as possible and getting it administered by local doctors who are trusted are going to A, make it easy and reduce the hoops that people have to jump through, and B, increase the trust level.
So did you look at male versus female in your studies as well?
Yes, so there is no difference between male and female. Neither of the people, they are just as affected, nor of the doctors. They are just as effective. And
there's probably no way, I thought even to might have racially mixed couples, because sometimes these decisions are made together, a family decision essentially. I guess you don't have data on
that we didn't look at. We didn't look at the couple level, even in the online studies.
Cool. No, very, very interesting. I think it's very, very helpful for how to design and how to get the messages across. Thanks a lot. Let me just see what I... So one question which came up, and let's conclude with that question, is that what's the external validity to other countries? Of course, you have done it in India, you've done it in the United States. How easily can you translate it to other countries as well, your findings? And how would you, did you find any striking differences between India and the United States? Where it's like, oh, these aspects we have to be careful, might be different from country to country. The social norms might be very different, in this country versus other countries.
So we never know. We have just those two countries, so I can't tell you for sure whether things would be vastly different in other places. But all I know is that it's a very different context where we get very similar results in terms of the impact of a light touch intervention. So that's, certainly give me some confidence that it would be worthwhile trying doing something similar in other places. The advantage is that it's so cheap. You can experiment on it before you scale it up, because the experiment costs almost nothing, and then the program itself costs almost nothing. So it's something where what you really, as long as it's the effect is anything more than 0, it is worth doing. You don't need to be more effective than something else, because this is something you can do on top of it.
So typically we have the tradition that we always start with a positive note at the end. So from your study, can you give us a positive aspect looking forward, or any positive note?
Well, I thought the entire talk was quite positive, yeah, but just because the results were quite positive. But I think the most positive note for me beyond COVID is this idea that people can just listen. That you put them in front of video messages by doctors, black doctors, white doctors, and they listen to what's being said, and they change their they are able to answer back the question correctly. They change their behavior, or for real after a few days. So I think in the context where we keep saying that people have lost, are unmoored from reality and do not trust expertise and so on and so forth, I thought it was very encouraging that actually that we found not to be the case in this particular context. It's at least if the information comes from a doctor, and if it's like simple and actionable, people will listen.
So this reminds me of Agnes Deaton saying either the doctors will come out as heroes or villains at the end, but it seems like your study concludes there will be the heroes, or will actually...
So far they are still the heroes, yes.
Thanks a lot, Esther. It was a pleasure to have you here, and I hope we see each other in the real world fairly soon.
Thank you so much. Looking forward. Bye-bye.
Bye-bye.